Everyone, thanks for joining us for this session. My name's James Beeson. I'm at the Burnet Institute here in Melbourne, and I'm going to be chairing this session on big ideas to address health inequalities. Of course, as we discussed in this morning's sessions, addressing health inequalities in Australia and globally is a hugely important topic. And I know it's something that you all feel passionately about and are committed to achieving in the long term. And I think we've all been aware of how the recent COVID pandemic has really exacerbated this issue of health inequalities and health equity. So in this session, we have four outstanding researchers and health professionals who will each give a short 5-minute talk about an ambitious concept or strategy to addressing health inequity and achieving equity in the long term. And how to achieve major gains in these areas, which really nicely picks up on some of the discussion from this morning and the questions and comments that were from the audience. After that, we'll have a panel discussion and encourage comments and questions from the audience here and anyone online. After each speaker, we'll just take 1 or 2 questions on their talk so that we allow most of the time for the panel discussion. All right, well, to kick proceedings off, it's a pleasure to introduce Professor Fran Baum. She's Program Director at Stretton Health Equity at the Stretton Institute, University of Adelaide. Fran is a public health social scientist with a special interest in creating healthy, equitable and sustainable societies. She's also a fellow of the Academy of Social Science of Australia and the Australian Health Promotion Association, and she's a past national president and life member of the Public Health Association of Australia. She also recently completed a term as co-chair of the Global Steering Council of the People's Health Movement, which is a global network of health activists. So to kick this session off, I think we're really fortunate to have Fran speak from her experience and perspective. Thanks very much.
Hello, and I'd like to start by acknowledging the traditional owners of the lands that we're meeting on, and pay my respects to their elders past and present, and also acknowledge other Indigenous people in the audience. Just a minute while I work the technology, there we go, that's great. So we were asked to think of some big ideas to address health inequities, and I've probably gone on over the top on big ideas, but let's see how we go in 5 minutes. I think the first thing is we've had quite a bit of talk about social determinants this morning, and I think it's worth putting those in perspective. There have been a number of studies that have looked, well, what's the contribution of sort of social economic factors compared to other health factors, and you can see there that it's about half probably of health is derived from that, as opposed to the physical environment, your genetics and the healthcare system making about a 25% approach. The thing when we think about social determinants and health inequity is we have to think that we're in a world now that is facing multiple crises. So we've got, most importantly, an ecological and climate crisis. And I couldn't help reflecting on the report before lunch. We didn't hear about that climate crisis, and yet every institution in our society needs to be dealing with that. And of course, that's leading to increasing disasters, floods, fire, drought, excessive extraction of fossil fuels, and so on, and also leading to pandemics as natural environments are disturbed. We've also had a financial crisis that had huge impacts in terms of austerity. In Australia, we've had low wage growth for most people, but very high growth for some. And we've all heard the threats of a global recession. We have many social crises. More people are reporting being lonely. More people are isolated. There seems to be less solidarity, less community spirit, much harder to protect culture. There's a rise of fundamentalism and a threat of terrorism. And I think there's also been a political leadership gap in the world. Many are just relying on what's now being shown to be outdated policies based on neoliberalism that tend to be pre-profit rather than the health of the population. I think someone mentioned this morning, though, that our current treasurer has talked about a well-being budget, so it'd be very interesting to see that. And of course, there's a lot of war and conflict, and also displaced people, which is a massive issue around the world. And all of this is leading to less optimal health outcomes, increases in chronic disease, mental illness, anxiety, depression, and new infectious diseases. So that's the broad picture we're looking at, and it is a very difficult one at the moment. In my book, Governing for Health, I noted that we need healthy public policy. So this is where, as I said this morning, the health system has an advocacy role to argue for this. And that means designing, crafting, drafting, and implementing policies that will think about well-being, that will say, well, how equitable is this? How sustainable are we in doing this? So, for instance, with the increased research in a health system, you might say, well, is that going to lead to equity? Is it going to lead to a zero-carbon health sector? And those policies need to be present in every sector. A lot of the work I do will be looking at urban planning, looking at the impact of energy systems on health and housing on health. And also noting that we both need those direct government actions towards well-being, but we also need a regulatory framework for the private sector. And Fiona, I thought it was interesting you raising privatisation this morning, because I think that's something that has had really big impacts on our health in the last few years. Now, in thinking about health inequity, that's what's happened to our Gini coefficient. I've just picked one thing because I don't think we really want to look at poverty in the people at the bottom, but let's turn our focus on where the power and privilege is, and you can see that that has increased dramatically. So if I was saying what I'd do about that, well, I would phase out negative gearing on houses, because that has had a really pernicious effect and created a housing crisis in this country, which has created a crisis of homelessness, which puts more pressure on the health system. Of course, I'd have a higher top tax rate for people who earn over, say, $200,000 a year, not a lower one, which is what we're facing in Australia. And I'd also tax wealth. And what that means is that we'd have more resources to do something about the things that make people sick and stop them getting sick in the first place. Much more investment in early childhood education as one example. Whoops. So in conceiving this with colleagues from the People's Health Movement, and then latterly with Professor Sharon Friel, who's becoming a fellow of the Academy, which is great, we've played with this idea to try and promote the idea that as well as biological vaccines, we need social vaccines to promote inequities. And in short, because it's only 5 minutes, but that is giving everybody a life with security. So no one fears falling below the net, not being able to afford healthcare, not being able to get a house, not having a job or income support, not having access to education. And of course, opportunities that are fair. So everybody has equal opportunities to education, that we would the idea that we currently subsidise some very rich private schools at the expense of low-income areas, particularly in outer suburbs, is really totally inequitable. So we'd have to ensure that opportunities were fair. And we have to have a planet that is okay for us to live in, is habitable, and that supports biodiversity. And at the moment, we haven't got that, and we haven't got any signs of that coming. And the climate scientists are warning us, if we don't take action, then all our efforts on health research, all our efforts to reduce health equities will amount to nothing, because this planet will become not livable on for humans. The planet will continue going around the sun, but it will not support the life of humans on it. And that threat is getting more and more. And then finally, we need just governance. We need to make sure that if governments spend money and they privatise it, that is governed well, that our politicians govern well, and that they take account of equity and health in all their policy decisions, so that the idea of health equity assessment becomes a routine thing that governments do. So that's my big ideas. I hope they weren't too big, and I look forward to hearing the others.
Should we take a question or two? People want to tackle any of Fran's big ideas. Otherwise, we can pick them up at the discussion at the end. Okay. I think happy to pick those up at the discussion at the end. All right. Okay. Well, our next speaker is Professor Jane Fisher from Monash University, and she's the Finkel Professor of Global Health and co-director of the Planetary Health Division in the School of Public Health and Preventive Medicine. She also leads the multidisciplinary Global and Women's Health Program. She's an academic, clinical and health psychologist with a long-standing interest in social determinants of health and healthcare participation. In 2022, she was awarded the International Marseille Society John Cox Medal for her work on perinatal mental health. Excuse me. She's also an advisor to international agencies including WHO, UNICEF and the UN Population Fund. So welcome, Jane. Thanks.
Well, thank you very much to Flavia and Ingrid for this invitation. I wanted to speak really about a similar topic, but perhaps from a slightly different point of view. I wanted to bring you some insights from the Global South. I've had the opportunity to do 2 studies in Vietnam 10 years ago, which was separated by 5 years. And at the same time, we mapped all the policies in this part of Vietnam that might have had an impact on health. And what we found was that women's lives changed a lot over this interval. So you can see that laws on domestic violence were introduced, laws on gender equity were introduced, and in particular laws on poverty reduction and hunger eradication. And over this interval, many aspects of women's lives improved. More were highly educated, more had secure salaried employment, and their reproductive health was better. They could choose when to have their first baby, and their pregnancies were more welcome. But most important was that the prevalence of mental health problems was significantly lower in the second survey than in the first one. And the 2 factors that were linked to this were that fewer women were experiencing coercive control from their partners and household wealth had improved. But there was not a single health sector change. There was no more services, no screening, no anything done for healthcare during this time. All of us are conscious of the enormous change in mental health at population level that happened during COVID, and there were many surveys, ours included, that demonstrated this enormous increase in mental health problems of some kind. And I think the fact that they increased, and then they increased differentially in Victoria when we had stricter restrictions than other states, demonstrates how much these problems actually reflect people's living circumstances. But they weren't evenly distributed. They were much more prevalent among people with the least resources, people who were in marginalised minority groups, people with disabilities, poor housing, lacking English fluency, and in particular for women, those who were providing an enormous amount of unpaid care for not just young children, but family members with disabilities or relatives who were aged. But the big risk on top of the pandemic was the impact of lack of financial security and the impact of interpersonal violence, especially that occurring at home. So I think our shift needs to be that mental health, which is currently conceptualised as a health problem, to be addressed pretty well exclusively within the health sector and pretty well only by individualised approaches to treatment, which are much more accessible to well-resourced people than less well-resourced people, and often are introduced without a huge amount of evidence that these are the best solution to the problems that we face. But there's been no consideration of the need for prevention and the need for mental health promotion and the need to equip people with understanding and skills to manage their own mental health. So I think we need a reconceptualisation that goes well beyond the health sector. Arthur Kleinman uses the term social suffering, which I think is actually a very helpful construct, and it reflects inequality. But what it requires is a whole of government response, and it needs to take into account community preferences and considerations. Both of these are missing at the moment. I would even go so far as to argue that it should be taken out of the health sector's hands and given to all the other sectors that influence people's lives and their well-being and their capacity for full social and economic participation. So my idea is that I would like us to invest much more, both intellectually and economically, in the structural and social factors that underpin this inequality in mental health, and really aim to improve the psychological well-being of the whole population by building back fairer, which is how Sir Michael Marmot is encouraging us all to think of our post-COVID responses. Thank you.
Okay, thanks very much, Jane. Our next speaker is Associate Professor Veronica Matthews. She's at the University Centre for Rural Health at Uni Sydney. And Veronica is a Quandamooka woman from Minjerribah, and her work centres on improving Aboriginal and Torres Strait Islander healthcare systems, incorporating environmental, social and cultural determinants of health through systems thinking and community-based participatory approaches. She co-leads the Centre for Research Excellence in Strengthening Systems for Indigenous Healthcare Equity, that's the STRIDE CRE, and she also leads the Indigenous Knowledges theme within the Healthy Environment and Lives National Network. Thanks very much, Veronica.
Thanks so much, James. And sorry, I didn't actually prepare any slides. I guess I'm sort of wearing one, which I'll get to eventually. But before I begin, I would like to pay my respects to the Kulin Nation on whose unceded lands that we're gathered on today. So as James mentioned, I work at the intersect of health and environment and have a very keen interest in climate justice for First Nations mob. And this is the perspective that I'm coming at from today. So the big idea that I'm going to talk about certainly isn't mine, and it certainly isn't a new one, but it's one that we really need to take seriously, or start taking seriously. For Aboriginal and Torres Strait Islander people have been talking about inequity and unfairness and how to address the wrongs since colonisation. Inequality hasn't come about through some law of nature. It's come about through actions and laws of man. Put simply, the 3 C's: colonisation, capitalism, and climate change. So just briefly going through those 3, as we're well aware, colonisation disrupted our way of life. There's been a lot of pain since. It's built on racism, the ideas of superiority and inferiority. It was really the beginning of the decline of our health and well-being. And these disparities are persistent today because it has become ingrained in our institutions. And I don't need to rattle off the statistics to provide evidence around that. Capitalism and its unregulated drive for maximum profits has been bad for our society. It's been bad for our economy. It's concentrated wealth in a few pockets, and this power has led to political inequality where money buys votes, and therefore the rich and powerful write the rules, mostly at the detriment of the rest of us. And extractive capitalism has handed us, I think, one of the biggest public health challenges, if not the biggest, of our generation, and that's climate change. And climate change is viewed by First Nations globally as an extension of colonialism and capitalism. Both continue to disrupt our close reciprocal relationship with our country, our environment, and now we are disproportionately bearing the brunt of extreme events in this country. First Nations globally are as well. So the floods, the extreme heat in Central Australia, the sea level rises in the Torres Strait. Unfortunately, socioeconomically marginalised people are more likely to live in harm's way of climate change. So the current system isn't working for us. It's not working for the majority of Australians, I would argue. So what is the solution? I believe, as do many other First Nations scholars, we need to return to First Nations' view of holistic health, where health is more than biophysical. It's also about deep, respectful, reciprocal relationships with each other, with our country, with the plants and animals who share the environment as well. And we need to stop placing ourselves in the centre of everything, the centre of the universe. Stop seeing ourselves as separate from the environment and separate from each other, and somehow being superior and holding dominion over the environment. And we need to dismantle the power systems that enable colonial and capitalist systems that drive inequality. And part of that blueprint, I think, is the Uluru Statement from the Heart that calls for a voice, a permanent voice to Parliament for Aboriginal and Torres Strait Islander people to have a say over the policies that impact them, a treaty, and along with that, some compensatory action in the form of strengthening communities, improving social determinants, preparing for climate adaptation, and truth. We must acknowledge the true history of this country and the ongoing effects of colonisation to understand the nature of inequality and to also come up with some effective responses. So the Uluru Statement is all about rebuilding genuine relationships, listening to mob and centering our knowledges. We need to relearn the principles of our ancestors and acting reciprocally and responsibly to look after country, look after each other, and most importantly, look after the future generations, and ultimately everyone will benefit. But just briefly, the work that the CRE that I'm involved in does takes on these principles of holistic approaches and relationality. We're building on the work of other First Nations scholars in sort of building the evidence in bringing Indigenous epistemologies and the research work that we do, working multisectorially. We've heard these themes before, outside of the health system, centering the voices of our communities in projects that are diverse, that do cover that holistic view. So, and that includes facilitating community-led climate mitigation and adaptation strategies. And I feel that it's these types of place-based, ground-up approaches, in addition to hopefully the mass public support behind the Uluru Statement to influence the upper echelons of power. I think this is key to transforming systems, to shaking systems up to address inequality. And you know, that's a concept that I know Fran has written about, 15 years ago, that nutcracker approach. So we need to start enacting some of those ideas. Thank you.
Thanks a lot, Veronica. And our next speaker is Associate Professor Peter Azzopardi. He's co-head of Global Adolescent Health Group at Burnet Institute and Program Lead for Adolescent Health and Wellbeing at SAMRI. Pete leads a program of research around global adolescent health with a large focus on analysing big data to identify priority health issues for adolescents at a global, regional and national levels. He was a contributor to the Lancet Commission on Adolescent Health and Wellbeing and has consulted on adolescent health for governments in Australia and the region. And he co-chairs WHO's Global Action for Measurement in Adolescent Health. Thanks, Pete.
Thank you. Terrific to be here with you on Wurundjeri land and to follow on from three really amazing pictures. Mine's a little bit different in that, but complementary, I hope. I'm calling that we actually invest in young people in a population group. And I think, well, I have no doubt actually that young people will help us address the challenges that we face today and the challenges that we will face tomorrow. I wanted to ground my presentation in this curve here, in the Heckman curve. Many of you may have seen this before. It's caused us a lot of problems in adolescent health. It really implies that investing in early childhood is where you need to be investing to address health inequity, and that your return on investment declines as you get older, and there's actually very little return on investment in adolescence. And we've seen that play out in the fact that less than 2% of the global development dollar has gone to adolescent health programs. Less than 2%, when we know that young people represent more than a third of the world's population. Fran, Veronica, Jane all highlighted the fact that the social determinants of health are really what drive health inequities. We're not innocent bystanders in the social determinants of health. We can shape the social determinants, and it changes during adolescence. It's really when we make our transitions from education to employment. And there are really different transitions that happen in different population groups. And so if we're not investing in the health of young people, if we're not giving them the opportunities to make the most of their education, to take on opportunities, then we really are setting people up for a life of social disadvantage and health inequity. And it's not surprising to see, well, it's not surprising for me anyway, to see that health inequities emerge during adolescence. This is a little bit of a busy chart. My colleague Alex Brown said, it's too busy, you shouldn't show all of this, but I wanted to because I think it really illustrates some of the important points. The graph on your left is a piece of work that we did with UNICEF. We looked at 100 indicators of gender inequality over 40 countries. Gender inequalities most consistently and markedly emerge during adolescence. It's not during childhood, it's during adolescence. And if we look at the health inequities that exist between Aboriginal and Torres Strait Islander young people and non-Aboriginal people, it's really during adolescence where the gap in mortality really opens up. And it's also where gender inequalities emerge as well. But I want to finish off here. Adolescence is not just where inequalities emerge. Adolescents, the people, are incredible agents for change. We've seen it over and over and over again. The new ideas, the energy, the enthusiasm that young people bring. Next year is going to be a huge year globally for adolescent health. PMNCH, which is an advocacy body out of WHO, is leading Adolescents 2030. It's really calling for us to look at how adolescents are being addressed within the SDGs. So I really hope that you join us all in actually thinking about how we can engage adolescents and address adolescents in terms of addressing health inequities. Thank you.
Okay, thanks so much to our four speakers. Really fantastic ideas, very stimulating and thought-provoking ideas. If I can get our four speakers to go up onto the stage to the seats over there, and we'll take questions and comments from the audience. I think we've got some strong themes coming through from today's speakers about seeing health and well-being in the whole picture, thinking about our environment, social determinants, economy, political environment are hugely important factors in thinking about health. All right, who would like to kick off with questions? Yes, Fiona, I think it is.
Thank you very much. Thank you for a very good session, obviously, something that I'm loving, the social determinants of health and the impact that they have. I just wanted to make one quick comment about the James Heckman diagram, which you're saying you hated the fact that we were pushing early childhood. But of course, adolescence is where early childhood really begins, and they're going to be parents in a minute. And if you don't get that, it's really, really crazy. And you could see that with your next graph of the Aboriginal parents starting to take off. But I really be addressing this, I guess, to Jane, but also to everyone. And everyone's always talking about whole of government. We need a whole of government response to this. We need always to get a whole of government. But it's incredibly difficult. The challenges are that bureaucrats fight each other for their budgets. Do you suggest that we have some way of overarching government, what we've been trying to lobby for? I mean, obviously we're lobbying for the wellbeing budget and getting rid of GDP as a singular measure, and how that's going to work across government may well result in some whole of government strategies for major issues, particularly things like climate change and child health and adolescent health and so on. But have you any thoughts about that from your international work?
Well, look, I think we do need an overarching mechanism, and it's naive to think this will happen spontaneously. So it needs to be an intentionally formed, but I think formed in a new way. And I would like to think that the traditional approaches, the mental illness, diagnostic, health detection of problems, that they're perhaps used as one option, but that we really try to harness the wonderful insights and ideas that people in much more diverse sectors have. I have some optimism that maybe the new policies about prevention might be a way through which we could do this, but it needs collective authoritative voices to argue for this, and of course it needs political will, and it will be opposed. So I think we've got to see ways through all that, but perhaps the collective voices of the Academy might be a useful way to start. Thanks.
I think next question up the back there.
Hi, John Keldor from the Kirby Institute. That's a good segue into my question, which is about the Academy and the Academy of Health and Medical Sciences. And I think there's quite a big contrast between the tone of this panel and the one just before lunch. And so I guess Fran pointed out that a lot of the big gaps in health are to do with the social and determinants. And within countries, I don't know whether that was within country or globally, but probably even bigger globally than it is within countries. So I guess my question is, how do we change what can the Academy and its members do on the research agenda to try to advance some of these ideas that have been put forward, or the needs? So it's one thing to say to government, you need to do this, but as a research and academy and a research sector, we best support that by research. So how do we advance our research agenda and enhance it to meet those goals? Thanks.
Thanks, John. I thought a lot about this question, and my tagline for it is that NHMRC mainly funds the M in its name, not the H. So that's the starting point. But of course, at the moment, the massive influx of funds we've had has been into medical research, not public health research. And yet there is such a big research agenda we can have around the social and commercial determinants of health. But I don't think at the moment the NHMRC deals with those applications very well. I mean, a lot of them would be from social scientists. The methodologies tend to be not like, a clinical trial, it's fairly clear what you're doing, but whereas the sorts of methodologies we're using are more complicated, probably more innovative, because the field of study is at an early stage. So, and my fear is if we have a Centre for Disease Control, that will sort of reinforce that, depending whether it has a narrow or a broad vision, that could sort of reinforce that. But I really think that NHMRC should be looking to fund that H much more greatly. And in response to Fiona's question, I could say that I think in South Australia, for a period there, we did have a health in all policies that worked. The reason it worked was that Mike Rann, who was our premier, he did two brilliant things. One, he had a state strategic plan. Every CE had to report against the targets on that plan. So they were interested in health in all policies because it would help them meet their target. And secondly, he transitioned very quietly South Australia to clean energy so that now we can have days of 100%. But he did that even within a privatised energy system. But most importantly, when we did have an NHMRC grant to look at that health in all policies, and it was because the CEs had to report annually against that, what was called SAFS, South Australian Strategic Plan, that they were interested in health in all policies. When that plan was downgraded and went away, it became much harder for the Health in All Policies unit to do that intersectoral work. So I think there are means of governance that you can introduce that give that push to public servants to realise that they need that work is going to give them brownie points, not detract from what they're doing. So I don't think that that's that difficult. It's just that we don't tend to do that at the moment with our public sector.
Fran, if I just comment, I mean, some of those points that you made reflect back on the summary that Christina presented about the Academy report for a need for a much more cohesive approach to funding health and medical research. This national level with the national bodies, whether that's NHMRC, MRFF or federal government, and state level as well, we have different initiatives, and getting that more cohesive approach is critically important, isn't it, to achieve and address some of the points that you raised. Jane, were you going to comment as well?
Just holding the mic.
Oh, okay. Great, thanks for that. Flavia.
One of the things I think we have to be very careful about, and Jane and I have had a discussion about this, but we're going to do all of government, okay? So then there's a light bulb moment with a minister and they rush off to their favourite expert. And in some ways, I wonder as an academy that one of the things we should be doing is really challenging some of the views of some of the older experts. You know, there was a very interesting show at Four Corners where, there was discussion about whether some of the eminent people around were blocking dementia research. As Jane was saying, it's very medicinalised, being miserable. And we need more help. But I do think that, if we're going to challenge ideas and get more ideas, don't we need to be challenging some of the views that are set by people that are eminent? Jane. Jane didn't want to discuss that.
Well, I don't think we should stereotype every older person as ossified and not open to new ideas because we're among them. But it's certainly true that it's much easier to cement what you believe very strongly to be true and to continue to do that. And so I really agree with what Peter said and with what Veronica said. We have to bring many more voices into this conversation, including young people, certainly people from First Nations, in ways that are really respectful and are not intimidating, and don't presume that because they might not have a research language, they don't have a valuable contribution to make. That happens in some projects in some places, but if it were made more of a requirement, I think that might lead to some of this shaking up. It is a considerable problem to have courage to advance new ideas and then to be able to actually realise or implement them. And I'm certainly convinced it's very hard to do it on your own. So finding a collective mechanism for doing it is important. And some of those very cemented voices might be ones we can try to moderate a little.
Thanks for that. I was going to ask as well if maybe Veronica could comment after Pete.
I just want to add to that comment if that was okay, James.
Yeah, you had a comment, yeah.
Yeah, no, I was just going to say, I totally support and agree with what Jane is saying. I'm sitting here on this stage as a mentee of the program, so I'm not a member of the faculty. And I know that there are many of my colleagues, even much earlier in their careers, who I think would not only make a huge value add to the academy, but I think would really appreciate the opportunity. So if that was on, if there was an opportunity to actually engage with, the broader sphere, I suppose, of people that are engaged in health and medical research in Australia through this faculty, it'd be fantastic.
Yeah, I think that's a good point, that obviously engaging health professionals in the academy's mission right through their career would be extremely valuable, wouldn't it? Yeah, Veronica, it'd be great if you could add any reflections on that topic. And one thing I was interested in was just your experience with how difficult or easy is it to engage political leadership from state governments, local governments, federal governments in rural health particularly, and Aboriginal and Torres Strait Islander health?
I would support everything has been said, and I would really encourage the academy, as we were just discussing in the quarterly session, around bringing in those diverse perspectives and actually, as a collective, supporting things like the Uluru Statement. And we were having discussions earlier as well that there are proponents in the room for the statement. I think you mentioned the old guys, right? And it will take, I think, a generational change, and that's where we need to start educating the young or starting back even at primary high schools about the issues that we've all just spoken about, so that people do get an exposure to the level of inequity that currently exists in our society. I think there's a certain sector that probably aren't so exposed to it and therefore don't know it exists. James, your point about influencing political leadership, it helps when you do have First Nations people in those leadership positions. So we do need to sort of plant our voices in different sectors to enable this the type of solutions, the big ideas that we're talking about today. So I've actually I found that the political sort of departments that I've worked with have been quite open to the ideas that at least our collaboration puts forward, because we've had those existing relationships, and they are often First Nations people in these positions. But I do recognise that they're only a small minority in those areas. So again, we need to build up our numbers in the policy sphere as well.
Great, thanks. There's a question up the back there. Oh yeah, go for you.
Simon Foote. So all of you actually said basically that government is the only real place where we can actually get support to do to make health equitable. I think that's reasonably true. So at the moment we're in a far from equilibrium situation where we have an empathetic government. And if you look around the world, things are even bleaker than they are here, where Europe and the US are pushing towards non-empathetic right-wing governments that actually do not historically support the sort of issues that you have raised that the government actually needs to support for success. While I am hopeful we will continue to have an empathetic government, what happens if we don't? Are there other ways of getting equity into the health system than relying on government?
Well, I wouldn't say you can ever just rely on government. In my experience, and certainly the research we've done on how policies which are moral are not equitable, civil society has always played a crucial role. If you think about any major social change, the abolition of slavery, votes for women, abolition of the death penalty, you go on, there's always a strong civil society movement behind those. Look at Iran at the moment over the veil. So, and the analogy I draw, which I think you referred to, Veronica, is a nutcracker. You need both. You need a government that will take the action from above, and you need the civil society action from below to really make the difference. Aboriginal health, I think, there's been a massive civil society movement. At the moment, we're looking at the history of the community health movement, including the Aboriginal community-controlled health services, and they came about because of a social movement, going back to the Black Power movement in the US in the 1960s, and you can trace those strands through. And Warwick Anderson, I'm looking at him because he's the historian on our study. But, the women's movement came about because of the feminist movement. The workers' health movement came about because of the trade unions. And it's people bringing those ideas and passion to the table and becoming advocate, and in some cases, of course, putting their life on the line, that forces the hand of government. Of course, there needs to be a government that is receptive and is listening, but I don't think there's been a massive social change where you haven't had that combination of a government and that bottom-up pressure from a range of civil society. And I mean, I guess I'd like the Academy to be part of that pressure on government from the bottom. I think we could be a very influential voice on arguing for health equity.
I think just to add to what Fran has said is the job's not done once. And for those of us with an interest in women's health, I'm completely shocked how the same things are prominent in young women's concerns now as they were 50 years ago. We seem to have made so little advance in some of these areas. So it's sustained action that's needed as well.
I think there was a mention of generational change. And Pete, you talked about investing in the adolescent group. I mean, they're going to be the leaders of tomorrow. They're going to be the champions of change to some extent. Do you want to comment on that, or there are examples you could give of that happening?
I just really couldn't agree more with, Fran, what you said. And I think that young people have been often at the centre of those social movements. I think I had, my 4 images there. The bottom corner was the Arab Spring, which was really, driven by young people. And again, we see it over and over again in history that young people can drive change.
Yep, great, thanks. I think there's another question just up there.
Hi, Shantha Rajaratnam from Monash University, and thank you to all of the panel for those really interesting insights. I wanted to ask Jane, I was really interested in the point you were making about making a mental health system that was reimagining it so that it was focused on prevention rather than working within a clinical system. I wanted to get some of your thoughts, because I totally agree with you, but I'm not sure where we start in developing a system like that, ensuring that it is accessible. Are you thinking in terms of a broad program that would be available through schools, for example, workplaces? And the second related question is, how do you make sure it interfaces with clinical services so that we don't create a silo and then potentially create more complications for people who fall off the positive or the preventative system and don't get access to the clinical services?
Look, they're such good questions, and I don't believe you can throw out the existing system and then have a complete gap while a new system grows. And I think prevention requires a long horizon. But for my money, the best investment is in early childhood, I know, and can progress to adolescence. But we know that young children's personalities, capacities for emotion regulation, capacity to problem solve, capacity to trust are really formed early, and they're really formed by their parents in particular, but others with whom they interact. And I don't think we can presume that parents have these skills spontaneously. So for me, there'd be huge investment in parenting education to enable people really to provide nurturing care that sets children off on a better trajectory. There's absolutely no doubt that mental health promoting schools are essential, and that's often, I think, a movement that young people themselves drive. The third place where I'd really focus efforts is in workplaces. I know this is your work and others here, that workplaces can do a lot to make people feel miserable, really miserable, and really powerless. They're dependent on an income, so they have to put up with a lot of bad treatment. So I think we have an opportunity now. We've got this plastic stage where people are working in new ways. I would love to see what we can learn and harness from that about the psychological benefits of not feeling oppressed, harassed, scrutinised, criticised, the bad bits of workplaces, and how we can attempt to build in the things that are psychologically enhancing. And then, of course, we have to think about people at the senior years of their lives, and there's lots we can do to improve the care people are given in that last decade and a half of their lives, including in residential facilities, which are pretty miserable places to be. So I would invest in those 4 areas, I think.
Great, thanks. There was a question up there on the left.
Hi, Anne Kavanagh. Look, it's just a comment really, but it was actually speaks to if you haven't heard Fran's talk that she gave in South Africa on the corporatisation of the modern university, I really, really, really recommend it. I think there are real challenges for us as academics in the system at the moment, which is has some perverse incentives for us to act in particular ways, keep our mouths shut, not challenge the system. which can be very toxic, as Jane's pointed out. I think that applies to a university workplaces quite well. And also in building relationships with government, even a currently so-called sympathetic government, you don't always get heard. So I really believe very strongly that our role as academics is to question government, is to question society, is to call people to account. But the system doesn't enable that. And in fact, I think we get rewarded for doing the opposite. So I'd just like some reflections on that. Thanks.
Yeah, thanks, Anne, and I'm happy to share. It was an academic freedom lecture that I gave in South Africa, which was T.B. Davey lecture, which is named after one of their former deans of research, who was apparently a very remarkable man. But in the lecture, I just looked at the space for an academic to be an advocate, to be an activist, and basically argued that the sort of corporatisation of universities is closing that space down, and that to do so now really puts your job at threat, puts your career prospects at threat. And of course, for democracy, it's really important that we have that academic freedom to be able to use research that we do and speak out about what will make things better. It's a really public good role of the universities, and my fear is that that's getting lost under sort of models of corporate management, of the desire to attract international students, so moving up in the rankings and so on. And I do think that those moves are, I know from many, many colleagues, making universities unhealthy places to work. And that's not a safe place from which people can advocate and argue for that public good. So I think you're making a good point there, Anne.
Can I just add to that as well?
You may need to use the microphone because I think that one's not working very well.
Yeah, I think universities need to be a place of ideas, right? And students, that's what they're there for, to learn and to engage with these big ideas and come up with their own. I mean, we saw Charlie Perkins at the University of Sydney and the Freedom Rides, and just how much impact that had on raising, I suppose, a profile of what essentially was apartheid here in Australia. So I think it does comes down to the collective. So many voices, if you're not isolated, I think that helps. And yeah, I wouldn't shy away from advocating and from speaking power to truth to power. That's the way it goes. Yeah, thanks.
Right, thanks. There was a question over there.
G'day. For First Nations people in this country, we live and experience inequity every single day. If I can share a story about syphilis in this country. 15 years ago, there were two populations in this country with syphilis: gay men and Aboriginal and Torres Strait Islander people, particularly young people who live in remote communities. We embarked on a national syphilis action plan that turned into the National Gay Men's Syphilis Action Plan because one lobby group was bigger and stronger than the other lobby group. My question is, and you've all talked about different agendas here, my question is, how do we pivot governments and others when we have multiple competing inequity agendas to address in Australia, and how do we ensure that those that have got the least voice are not left off the agenda into the future? And interestingly, I know that racism comes into play. Institutional, structural and personal racism comes into play with inequity, and not one of the panellists has talked about racism. And so I think we need to really open up the conversation about racism in this country at all levels if we are truly to address inequity. The other part of syphilis is that it's now starting to creep into non-Aboriginal women in this country, and there is a massive response for non-Aboriginal women. Yet the rates of syphilis among Aboriginal women in this country are about 15 times higher than non-Aboriginal women. And yet we can accept that and move on to the new agenda of addressing syphilis in non-Aboriginal women and continue to let it happen among our people.
Thanks, James. That's a tough question. I know, for instance, the recent syphilis outbreak, across the north of Australia, not that long ago, hardly got any attention. Aboriginal and Torres Strait Islander issues don't get any attention in the media, and again, it comes back to the power, right? The media monopolies choose what people need to know. So I don't have the definite answer, but again, it's shaking down those systems, and it comes down to really collectively getting together marginalised voices to shake down those systems. It's going to take a concerted effort, a lot of effort, but yeah, sorry, that's probably not very helpful.
I think that was a great example, James, of that political engagement in an issue being so, patchy or selective, and so I think I'm interested to hear from people. What is it that pushes a politician or a political group or political leadership to embrace a topic, embrace an issue? I mean, often politicians will say they're reactive. Typically, the environment is very reactive. But once you get that issue to a high enough urgency in the mind of the politician, then there's action. So how do we, what are people's experience and how do we tip that? But Jane, were you going to comment first?
Well, I first wanted to apologise. I realise I shared that oversight, and yet our data revealed that. And it's a sort of example of how the environment shapes our blindness as well. In ensuring that these horrifying accounts that you describe are not just the responsibility of the people who are affected. And I don't think we're nearly good enough at that, at ensuring everybody supports accounts of lived experience of these inequities, but doesn't expect that people have to be the champion of their own needs always. And, I would very much like to see ways in which we can do that more effectively. And it certainly means ensuring that we find better and newer ways of bringing these to public attention. The thing I think that I would like our politicians to be more open about is their own moral positions. So they're very committed to the political needs that they need to serve, but I would like to know morally what are some of the things they believe to be fundamentally wrong that they would like to commit to address.
Thanks, James, for your question. And of course, the research we've done has shown very clearly how racism affects Aboriginal people's poor health, and it's shocking. I was shocked by the extent of racism that was reported by people in Adelaide, and it was terrible. But, I think the answer to your other question is I really believe that universalism is really important. So then you're not putting one group against another. And Michael Marmot's group introduced the idea of progressive universalism. And it seems to me so often we say, oh, those populations are hard to reach. Well, I think we turn it on its head and say to those services, why are your services hard to reach? So you'd say in the Northern Territory, you'd say take two diseases like rheumatic heart disease, which is also very prevalent amongst Aboriginal populations, and syphilis or whatever, but it would be the responsibility of the services to do it, because their performance indicators would be ensuring that everyone had a syphilis-free community. Whereas at the moment, it's kind of almost on the people, you haven't got access to services because, you live there, you've done this. Whereas an assumption of universalism just turns that around, and it's the responsibility of the service to ensure that it is accessible, whether that barrier is racism, whether it's transport or cost or whatever. So I think, we really need to move much more back towards universalist services that then do that progressive work with groups who face particular barriers to access, and that might you won't be sort of bouncing off gay men against Aboriginal populations, which is a terrible situation for the country to be in.
Yeah, I mean, it's a reflection of one of the failures of the political system, isn't it, to deal with priority health issues when they're staring you in the face. Other questions? Yeah, Fiona. Yeah, you can have another one.
It's really, I guess, a call to arms in a way, because I was going to mention the proposed Centre for Disease Control, and Fran mentioned that this might be a vehicle. But what's come out of the session for me is what comes out of these sorts of sessions all the time. I wish we had some benevolent dictator overseeing the health system who could say we need more on prevention, we need more on early childhood, we mustn't forget adolescents. Let's look at this distribution of how we're funding both our research and our services, rural versus etc. There isn't such a benevolent dictator. We all could have tried, couldn't we? But anyway. So maybe we should come at this as a faculty, as an academy, to say, we want a CDC that looks like this. And it's not one that's just based on infectious disease or COVID or the next pandemic. That would be a huge mistake, because we've got an opportunity to say we could make this a much more holistic centre which would understand the social determinants of disease, the racism determinants of poor health outcomes, and a whole lot of other things. And it's much more than just health, because all of the pathways into poor health are the same pathways that are into poor education, are into detention of juveniles, into all of these things that, as we know, early childhood agenda, that's why we made the case for these. So is it beyond the realms of possibility with this particular government, with the Teals and the Greens on board as well, that we lobby intensively to make this a holistic, whole of government CDC for Australia, and you could then have a whole group working in the CDC on racism or on social determinants or on syphilis in Aboriginal communities? It seems to me that would be absolutely fantastic if we could make some kind of major statement on that.
I think there was pushback from the last federal government on that concept, but I think it really comes back to us as a academy to say we've got to be in there for the long haul, don't we? And really persist with a concept that we think is important. We're running out of time, so I'll perhaps have this. Did the panel want to make comments on that? Did anyone on the panel want to make comments?
I just endorse it completely. Yeah. I think it would be a wonderful use of the collective power in this academy to do that.
Shall we take the last question?
So a colleague did an analysis of the ministerial diaries in Queensland and New South Wales, and the most frequent and for the longest period of time going in to see the health minister was the AMA. So wouldn't it be fantastic if the AMA, supported by the academy, was actually saying, Minister, your top 3 priorities are addressing racism, addressing the underlying structural determinants of health inequities, and I can't think of what the third one, but of climate change and health, because I'll speak about that. But so it's about the power of who's getting in that door, and just sort of building off of the argument for the CDC. But we know the voices that are getting in the door. One of the impacts, the research impact that arose from that analysis was that the ministerial diaries became rather vague. So it was not the impact that was really wanted in that regard. But joking aside, that type of data tells us who's in the door, and so therefore using those voices to really advocate for this type of action.
Any comments from the panel?
Yeah, and I'm sure the big food industry wasn't far behind. There's a famous episode of Utopia, I think, where the food industry person gets taken straight through to the minister and the public health people are siphoned off to a junior office staff, and yet they both had access to the minister. So that question of power is really important, and who has access to it.
Okay, well, thanks everyone. We need to bring this session to a close. And please join me in thanking our 4 panellists.